A little bit about treatment. Start by saying that there's no cure for Alzheimer's, and it is a fatal illness. Typically, from the time of diagnosis, is about 8 to 10 years before the person dies. Alzheimer's is increasing in terms of the number of people dying. You know, the deaths due to cancer and heart disease are declining. The deaths due to Alzheimer's are all rising. And Alzheimer's is now about the 5th or 6th most common cause for death in the United States. So there is no cure. We do have some medications that I'm going to talk about, but often non-pharmacological approaches are helpful. For example, simplifying the person's life, making their environment, laying out the clothes for them, using simple medicines to control pain, clothing that's easy to get on and off, helping with simple bathing. And when we look at medications, now let's switch to that. We only have medications that really help the symptoms. And what we really like to have, is something right here. We like to have something that once we've identified a problem, we could give and we could alter the course of the disease. Something called disease-modifying therapy. Right now, there is no such thing. There have been many clinical trials looking at targeting those proteins that I talked about in the last 10 or 12 years, and they've all been unsuccessful. And it's sort of discouraging. You know, we have multiple new drugs for diabetes, we have new drugs for cancer, but in the last 10, 12 years, we don't have any new drugs at all. So this is the holy grail right here. If something like that could be developed, it would have huge consequences in terms of this problem. So right now, we only have what's called symptomatic therapy. We can give medications that will help reduce the symptoms and alter the course of the illness a little bit this way. So here we've got, again, brain function, cognition. We give the medication. We may see some improvement in memory, but again, we eventually get back to that downward spiral and ultimately lead to death down here. I wanted to mention that the medications do not make a person live longer, and sometimes that's a concern about patients' families. They think, oh gee, this is an incurable illness, and we're just going to be prolonging the misery if they're on medication. Patients don't live any longer on the medication, but medications do have some benefits. These are the medications right now that have been are used for Alzheimer's. They have clinical studies backing their use. The first three all fall into the category of acetylcholine esterase inhibitors. Probably the most commonly prescribed one is donepezil, which is Aricept. These come in pill form. One of them comes in a patch that can be applied to the skin. A second medication is called memantine. It works on a little different neurotransmitter in the brain. The first four are all FDA approved for treatment of Alzheimer's. And then vitamin E has some data to suggest that it is also helpful. And that is not FDA approved, but there's good studies to suggest it's helpful. A number of things have been tried, and I just wanted to mention that. All of these substances have been studied to see if they help Alzheimer's, and in each case they have not been proven to be helpful, so I thought I would just list them. Ginkgo is an herbal product, antioxidants, which are many vitamins, statin drugs, which are cholesterol-lowering drugs, anti-inflammatory medications, vitamin B, C, anti-epileptic drugs, fish oil, and hormones. All those have not been helpful. And they have good studies to say not worth trying. So, what do the drugs actually do? I mentioned they do help symptoms. They help memory and language. They can help somewhat with function, such as grooming and finding belongings. It may help with some of the behavioral problems we see with Alzheimer's too, such as agitation and irritability. When they talk about using drugs, they talk about reducing the caregiver burden. And Caregivers spend hours often looking after someone with Alzheimer's, and if we can reduce that from 3 hours a day down to an hour and a half a day, well, maybe that's an accomplishment. Some of these drugs seem to help with some of that. The other thing they do is seem to delay the time to nursing home placement, and when you think about the costs involved with nursing home, that is an important aspect of using the medications. But again, it does not extend life. So is there anything that could be done to prevent Alzheimer's? What about brain exercises? Well, one of the leaders in the Alzheimer's field gave this quote: "There's good but not definitive evidence that memory decline can be slowed." And I'll talk a little bit about some of the things that have been shown to have some benefit, but keep in mind that even doing all these things is not going to head off Alzheimer's if it's in the cards for you. But it may delay its onset and may slow its progression. There's a concept of something called cognitive reserve, and this gets back to the point that people who have a more formal education, say have gone beyond high school, college, have less likelihood of getting Alzheimer's disease. And there's some thought that, well, there's this cognitive reserve there that maybe protects them somewhat from Alzheimer's, so that some element of lifelong learning may provide some protection. So taking a class, learning a new language, learning a new skill may actually provide some protection going forward. Another aspect of this is that a fit brain is considered a healthy brain. By that I mean if the heart is healthy, the brain is also going to be healthy. So focusing on the things that keep your heart healthy, exercise, avoiding smoking, managing cholesterol, those things will also impact on your brain health. So some of the things that have shown some benefits for preventing dementia: again, don't stop learning, exercise your heart, get adequate rest, sleep makes a difference. Be social. People who are interacting with other people are exercising their brain. A person who sits home and watches television all day probably isn't. So being out and about, avoiding brain injury, challenge your mind. So some of the older folks, they'll do the crossword puzzles, they'll do the puzzles in the paper. There's some value to that. And it's thought to be that exercising both the left brain and the right brain, so doing music, but also more concrete things of mathematics can provide some protection. And then manage your heart and blood vessel risk factors. So that concludes what I wanted to say, and so we're next going to ask a couple of representatives from St. Francis to come up and talk about the virtual dementia tour, and hopefully we'll have time for plenty of questions.
Good morning.
Good morning.
I'm not 29 yet, so I think Dr. Strong just called me the smartest person in the room. I'm excited to be here today to tell you a little bit about an initiative we've been working on at St. Francis Home related to dementia care. Throughout the last year, we've worked heavily on getting all of our associates at St. Francis Home through an activity called virtual dementia tours. We continue to conduct these tours with all of our new hires at our new associate orientation, and we've also conducted these with the Agnesian executive team, our St. Francis Home leadership team, and we've also offered it to family members. So what does dementia look like, feel like, sound like to us? It might look like some of the people on the slide here, this person being a frustrated caregiver, or maybe the other two pictures being a lonely or grumpy elderly person. You might be asking yourself, what exactly are virtual dementia tours? This process is the best that science can tell us as to what it's actually like to have dementia. The process starts out with each person completing a pre-test to gauge the current state of mind before going through the tour. Next, each person gets scarfed up in various pieces of equipment, which Deanna will go into detail a little bit more later. Before they enter a mock apartment, they are told 5 tasks that they need to complete. They are then sent into the apartment and need to try to complete all 5 of those tasks. The tasks cannot be repeated, and we are not allowed to answer any questions once a person is in the apartment. After 10 minutes or so, they are then taken out and their tasks are tallied. A post-test then gets completed, asking what their current state of mind is like after going through the tour, and a short discussion group takes place. So what did the tours do for the associates at St. Francis Home? By experiencing some of the challenges these individuals face every day, our associates are able to provide even better care to our residents than they were before. And here's a quote that states, "The greatest form of respect we can give is to walk in someone else's shoes," which is very reflective of what we've been trying to accomplish with conducting the virtual dementia tours with our associates. So now I'm going to hand it over to Deanna to talk a little bit about the various items of equipment that we use, and some of the takeaways that we found when conducting the tours.
Jen's going to stay up here and model some things for us.
Dream come true.
So garbing up. Participants are garbed with equipment that imitates what individuals with dementia might experience. So the equipment is put on before they enter the apartment. The instructions are read. There's headphones on that are playing some sounds, and we will play some audio for you on that in a later slide. 5 simple tasks are read. Some examples of the tasks are find the white sweater and put it on, write a 3-sentence note to your family and put it in an envelope. They're in the apartment for a total of 10 minutes. 5 minutes later, another participant enters the apartment with a different set of tasks. The room is dark, and we'll get into the reasons for that as we go, and there's a strobe light going. So, the glasses are the first. When someone is first diagnosed with dementia, you'll see the goggles here. Can everybody do this for me? When you're first diagnosed with dementia, that is what you can see, and that's what your brain can take in. As the disease progresses, it gets smaller and smaller, more like binoculars. So you're not seeing anything out here. You're seeing what's in a very small box in front of you. So that's something to keep in mind. The aging pupil creates a constant need for more light. That's why the room is darkened. The black dot in the middle of the glasses simulates macular degeneration. Jenna, if you want to put the glasses on and show them. And we're going to pass some of them around so you can try them on if you like. And as the occipital lobe of the brain deteriorates, your peripheral vision is lost. Are they getting past? Oh, they are getting past. Okay, sorry. All right. Next we have the audio, and I'm going to play that for you. This is what people are hearing while they're in the tour. I'll stop that. That's kind of irritating, isn't it? So are individuals with dementia really hearing that all the time? No, I don't believe that. What that's telling us is that what's coming into their brain is coming in all mixed up. They're not processing like we process. Okay? The next thing is the shoe. Did I miss one? Sorry. All right, the gloves. Jenna will show those. So imagine wearing a pair of gloves like this and trying to do a simple task like buttoning your shirt, putting on your socks, brushing your teeth. What the gloves mimic is a loss of mobility and fine motor skills. There's also a decreased sensitivity if someone's injured. If they burn their hand, they might not feel it. All right, the shoe inserts. We do sanitize these between each participant, if you were wondering. Oddly enough, some of the staff think those were the most horrible things that they ever had on their feet, and they were walking like this, and they were really uncomfortable, and other people thought they felt great. So I'm not sure why that is, but they did. But the point of it is, you can see what some of the poor circulation, neuropathy, and or arthritis. But if you have any experience with people with dementia, you very rarely see someone walking with a nice stride. They're almost always shuffling their feet, balancing their weight, things like that. All right, behaviors. We've done over 200 participants. As Jenna said, we did the executive team. all of St. Francis Home employees. We're doing new hires. We also did an evening where we did interested family members, and that was very interesting as well. So when we have the discussion group, we talk about what behaviors people with dementia have. People with dementia may swear. They may even be combative. They may strike out. They might shadow. Shadowing is maybe they really don't know what to do, so they just kind of go along with what someone else is doing. Sub-vocalizations, they might talk or whisper to themselves. They might hum or sing to themselves. Requests for help. If you've been exposed to someone with dementia, they may ask lots of questions. What am I supposed to do? Where am I supposed to go? Can you help me? Please help me. Things like that. Wandering, we have people who like to pace. Hoarding, they might be grabbing stuff up in their environment and taking off with it. That's a very common thing that happens. So the question that comes through in all of this is, are these really truly behaviors, or are they coping mechanisms? Because what we find when participants go through the tour is they're exhibiting some of these same behaviors. And that's what we talk about. We talk about each person, what they were observed doing during the tour, and what behaviors they had. Some of the things participants have said are things like, I'll be more patient, I never realized. I'll only ask one thing at a time, and I'll be face to face when I talk to someone. Family members have said that, boy, when I go into my mom's room, I'm doing all kinds of stuff, going through her drawers, trying to help her, and I'm talking to her, and now I realize she's not getting what I'm saying. Another thing, I'll remember to let them know when they do a good job so they have a sense of accomplishment. Sometimes as caregivers, I think, as the disease progresses, we forget some of those things like hand over hand. When someone's losing their ability to feed themselves, to do a hand over hand, get them going so they can maybe feed themselves part of their meal, or brush their teeth, things like that. And a lot of people have said, now I know why resident so-and-so does this. I never understood. So, the better that we understand what the people we care for are going through, the better we can meet their needs. You know, we can tell our associates, this is how you approach someone with dementia, this is what you should do. But for them to actually feel what it feels like to have it, leaves a real lasting impression. So this is similar to one of the slides Dr. Strong had, but this is worldwide. Talk about population management. 115.4 million people with dementia worldwide. That's huge. You know, how are we going to deal with this in the future? So obviously that's why it's important, and we're really looking at, because there is no great cure, how can we approach this, and what can we do to modify what we do as loved ones and caregivers for the people that we're serving? Questions?
For us or Dr. Strong?
Yes.
When people get into this stage where they're trying to elope from wherever it is they're living in a protected care environment already, not just in their home, far later than that. What are some of the strategies and interventions that are helpful then? I know about the alarms and all those things. And,
yeah, we have wander guards.
Yeah.
A lot of times, they used to teach people to do reality orientation, which can be really mean when you think about it, but they used to teach us, somebody might be looking for their baby. They might be looking for their mother, depending on what stage of dementia they're at. And they used to tell us to say, oh no, you live in the nursing home, you're 90, your babies are grown, your mother is dead. They don't teach us to do that anymore.
No.
They teach us to maybe talk to them about, if they're talking about their baby, tell me about your baby, tell me about your home, get them distracted and moving on to things. And generally that works, and sometimes interventions that we try work one day, they don't work the next day. We often have to modify our approaches. It's a challenge.
It's called
But it is with
therapeutic
verbal
fibbing.
cues. So it is with verbal cues primarily then, though.
Mm-hmm. One of the other things is that, we really need to look at our environment and try to have smaller areas for people that aren't so quiet. People that go through the tour are like, wow, I never realized how overstimulating everything can be be, and to have the less stimulation is really important.
Having experienced that in my own family, some of the best advice that I got from my mother's psychiatrist was, rather than a bunch of us going all at one time to see my mother, it was better doing it one-on-one. And if she seemed to be existing between ages 40 and 50, because that would be what she would talk about the most. So Dr. Tapp also suggested at that time, when she does that, just let her talk about it, and I'll tell you, it made for much better visits, because she used to, she would be so agitated, and she got so flustered and overwhelmed by everything that we had to modify the way we were doing things, and that did make for a much better situation for my mother and for us.
We've had family members that, they want their loved one to be successful, so they'll come up and say, what's my name, Mom? Who am I? And that's scary when you don't know. Instead of saying, hi, Mom, it's Deanna. How you doing today? Or what'd you have for breakfast sometimes becomes a super important question of a family member. Who cares what they had for breakfast? They don't remember. That's hard.
Dr. Strong, you mentioned a number of things we can do for prevention, be social and keep your mind active and so on and so on. Is obesity tied to Alzheimer's or dementia in any way? I mean, if you help me there.
Clearly, diabetes is, and so obesity is a risk factor for diabetes. I'm not sure that I've seen obesity in and of itself has been shown to be causative, yes.
It comes as a result of other comorbidities that then create dementia.
Yes.
Why do they say that it's more prevalent in women and men?
I think because women live longer.
Right, women live longer, for one. But I think even beyond that, though, it is more common in women, not just an age-related effect.
Is it stress maybe related, or?
I'm not sure people know why more in women than men.
Because our brains have versatile problems.
You want to start that response?
Oh, it's just wondering where diabetes fits in there. I mean, I'm type 1, so am I more at risk than?
Yes, you are. Probably 2 times, 3 times more at risk compared to average. So it is a risk factor.
Is that because of the lows, that some of the brain cells die when you have too many lows?
Probably has more to do with that vascular component. It's kind of interesting, if you take a group of people that the doctors all think have Alzheimer's, pure Alzheimer's, and then you go and do post-mortem studies, brain biopsies, I mentioned that a substantial portion of them have also these vascular lesions. So maybe that some of the benefits we see from exercise and controlling cholesterol and diabetes would help to prevent that vascular part that we see in many people as a concomitant condition with Alzheimer's. So, as you know, diabetics are more prone to blood vessel diseases, hardening the arteries, heart attacks, and it probably carries over to the blood vessels in the brain as well then.
So lifelong learning and brain stimulation is good, but is there too much that can be damaging? Like too much stimuli, phones, and all these other things we have in our life to multitask.
Well, stress is considered probably also a risk factor. So if you're having so much stimulation, you're not sleeping, and you're not taking care of yourself in other ways, eating well, exercising, then that's going to have a detrimental effect. The question is, would a Cerner upgrade be good for your brain or not good? So it's good that you're learning new things, but if you're not sleeping at night, that's not so good.
Do you suggest that we take extra vitamin E then, and if so, how much?
Well, the studies with vitamin E were on people that have actually been diagnosed, and the dose was 1,000 units twice a day. But I would not recommend that for the general public. The reason for that is there was a study looking at vitamin E. And interestingly, people that took more than 400 units a day had an increased risk of dying, mortality. That's in the general public. So we generally recommend people not take vitamin E exceeding that dose. But in the subgroup that has Alzheimer's, they did not have an increased risk of dying and actually did a little bit better in terms of their cognitive function. So as a prevention, vitamin E would not be something I would suggest.
Janet, do you have a question?
Yes, sometimes when you approach somebody that is maybe having early onset dementia or Alzheimer's, they're resistant or they're not ready to see anybody for that. Is there a service or like can you make an appointment with a doctor to talk about your family member or their doctor to tell them, okay, now when they come in, everything might be right and here's what I'm seeing, or you know what I'm
Sure.
saying?
What I would suggest in that kind of situation is that you talk to that person's personal physician and even mention the person doesn't want to talk about it, but the doctor can bring that up. And what I found is that people are open to being tested. I think most people are actually concerned. Say, well, you know, we all lose little memories as we get older, but would it be okay if I asked you a couple questions to see how you're doing right now? People say, oh, sure. I have very little resistance to that. But those observations that you have as a family member are really important to convey to the healthcare provider because they provide so much more information than that person is going to volunteer. And I think that's probably the approach that I would take.
Jenna, what percent of residents that you're caring for at St. Francis Home do you estimate have dementia today? Just as
67%.
67%? Oh my God.
And that's a national figure, about 65% or so of people in nursing homes have dementia. It's a big number.
We have time for one more question, I think.
The usefulness of like a Depakote or a Lamictal, how often do you use that in your patients? I remember the slide that said the research doesn't really bear out that it's, you know, do you still try it?
I think the trend has gone a little bit away from using some of the anti-seizure drugs for the behavioral problems with Alzheimer's, but we don't have any drugs that are approved for treatment of behavioral problems of Alzheimer's.
Do you get some mood elevating?
Yes, so
from
those type of drugs are still tried,
Yeah.
definitely.
Yeah.
Definitely. Yeah.
All right, thank you very much, Dr. Strong, Jenna.
All right,
Yeah.
thank you very much.
Does Katie have everybody's green card for the drawing?
No.
No? Okay. Any more? All right.
I'm gonna have you pick 3 names.
3 names?
Yes.
Okay.